Dear friends and colleagues, today I am excited to present to you my study, which I completed 5 years ago. The focus of this research is on the challenges presented by limited mouth opening in endodontic procedures and the performance of different night-eye instruments under these conditions. It's one more tip that you may use in practice in same situations. Now let's consider a practical scenario. The patient has experienced limited mouth opening throughout his life and recently underwent surgery to remove squamous cell carcinoma from his lower lip. As a result, he presents with significant limited mouth opening measuring barely 20 mm. Upon examination, it becomes clear that tooth 26 required root canal treatment. However, the limited space between his molars creates an obvious challenge. I have very little space to prepare the tooth using traditional high-speed handpieces and standard round burrs. Limited mouth opening (LMO) can significantly impact endodontic procedures and is defined as the inability to open the mouth beyond a certain threshold, typically around 20 mm in affected patients. The average range of mouth opening is normally between 35 to 45 mm. Several factors can contribute to LMO, such as temporomandibular joint disorders (TMJ), conditions affecting jaw movement and muscle function, submucous fibrosis, a precancerous condition that affects the tissues of the mouth leading to rigidity, scleroderma, tightening of the skin and connective tissues, including those in the oral cavity, malignancies or ankylosis of the TMJ, tumors or joint fusion that restrict movement, post-surgical conditions following surgeries on or around the jaw can often lead to restricted opening. This study aims to compare the effectiveness of different night-eye file alloys when used in conjunction with contracted endodontic access cavities under simulated LMO conditions. Study design: 4 types of night-eye instruments were taken. First, M2 with size 20 and shaping 6. Second, Pro-Taper Universal S2 with size 20 and taper 4. Third, 2-Shape TS1 with size 25 and shaping 4. And fourth, DC taper size 20 and shaping 6. Measurements taken from artificial molars placed in a dental mannequin with LMO set at 20 mm. A total of 320 measurements were performed by both general practitioners and endodontics residents to measure file insertion times. Result: the DC taper showed the fastest insertion times among all instruments, with significantly improved performance when compared to M2, PTY, and 2-Shape. No unsuccessful insertions were recorded for DC taper, showcasing its efficiency in managing the challenges presented by LMO. The average fits reveal consistent result between the 21 mm and 25 mm length for DC taper, with no significant difference. Conclusion: CM wire instruments prove to be advantageous in navigating limited anatomical access, which is often encountered in clinical practice. Thank you for your attention. Let's discuss any questions you may have about the study or its implications.